Welcome, everybody. Thank you for joining this webinar hosted by the Maternal Health Learning and Innovation Center, featuring the Black Mamas Matter Alliance. It is going to be a lovely presentation. We are in meeting form here, which means our chat is live. If you'd like to introduce yourselves, we welcome you to. However, we ask that you stay on mute during the presentation period, at least until we get to the Q&A. My name is Allison George. I am part of the training team at the Maternal Health Learning and Innovation Center. And I'm working on getting these slides to advance. There we go. MHLIC was founded in 2019. We are funded by HRSA, and we work in partnership with a number of phenomenal organizations listed here. We are honored today to host Black Mamas Matter Alliance and 3 panelists that they have invited to join us today. It is my pleasure to introduce to you Dr. Ayanna Robinson. She is the Director of Research and Evaluation at BMMA. Dr. Robinson, over to you.
Thank you, Allison, and good afternoon, everyone. Thank you again for joining us. It's great to be here to present our second webinar in this series titled Engaging Communities in Maternal Mortality Review Committees to Move Data to Action, Lessons from the Field. Next slide. This slide provides an overview of the next hour. We will have Q&A at the end, and the chat is also enabled, so please feel free to enter your questions throughout the presentations. Next slide. The Black Mamas Matter Alliance is a national network of Black women-led organizations and multidisciplinary professionals whose work is deeply rooted in reproductive justice, birth justice, and the human rights framework in order to ensure that all Black mamas have the rights, respect, and resources to thrive before, during, and after pregnancy. BMMA honors the work and historical contributions of Black women's leadership within their communities and values the need to amplify this work on a national scale. Next slide, please. Our alliance spans 24 states and includes a diverse range of professionals from midwives and doulas to OBGYNs, nurses, lawyers, academics, and public health researchers. Our mission is to center Black mamas to advocate, drive research, build power, and shift culture for Black maternal health rights and justice. Next slide. We always like to define Black mamas. So when we say Black mamas, the term represents the full diversity of our lived experiences. That includes birthing persons, including cis women, trans folks, and gender non-conforming individuals that are people of African descent across the diaspora. We recognize, celebrate, and support those who care for and mother our families and communities, whether they have given birth or not. We stand in solidarity with all Black mamas. Next slide. The work of BMMA spans our 4 bucket areas, which include changing policy by introducing and advancing policy in the human rights framework that addresses Black health inequity and improves Black maternal health outcomes, cultivating research by leveraging the talent and knowledge that exists in Black communities, and cultivating innovative research methods to inform the policy agenda to improve Black maternal health. Advancing care for Black mamas by exploring, introducing, and enhancing holistic and comprehensive approaches to Black mamas care. And last but not least, shifting culture by redirecting and reframing the conversation on Black maternal health and amplifying the voices of Black mamas. Next slide. BMMA publishes our work across our various bucket areas within the within different topics, including our holistic care principles, our research principles, and our reports on our work supporting MMRCs. All of our publications can be found on BMMA's website. In addition to our alliance, BMMA has multiple programmatic efforts, including Black Maternal Health Week, Founded by BMMA, Black Maternal Health Week has been celebrated for 7 years. Last celebration was in April and is a national initiative that takes place annually from April 11th through the 17th during National Minority Health Month. Black Maternal Health Week is a week of awareness, activism, and community service to amplify the voices of Black mamas and center the values and traditions of the reproductive and birth justice movements. More specifically, Black Maternal Health Week deepens the national conversation about Black maternal health in the U.S., amplifies community-driven policy, research, and care solutions, centers the voices of Black mamas, women, families, and stakeholders, provides a national platform for Black-led entities and efforts on maternal health, birth and reproductive justice, and enhances community organizing around Black maternal health. Next slide. Also founded and led by Black Mamas Matter Alliance in 2018, the Black Maternal Health Conference and Training Institute is the premier assembly in the U.S. for Black women, clinicians, professionals, advocates, and other stakeholders working to improve maternal health using the birth justice, reproductive justice, and human rights frameworks. Registration is open now for our Black Maternal Health Conference and Training Institute 2024, which will take place in Atlanta, Georgia from September 12th through September 14th, and we hope to see you there. I will now pass it over to Sang Hee to provide an overview of BMMA's work with MMRCs.
Thank you so much, Dr. Robinson. Good morning, good afternoon, everyone. Thank you so much for joining us. I think at this point, a lot of you have heard information about our Maternal Mortality Review Committee project and report. Next slide. But just to give some background to frame the presentations from our panelists, I'll just give a brief overview. So in 2021, BMMA conducted an environmental scan of 9 state maternal mortality review committees throughout the United States to strengthen the capacity of MMRCs to better integrate strategies toward equitable practices across their processes. As part of the scan, BMMA spoke with community members who reported on the challenges and opportunities they faced while engaging or trying to engage with MMRCs. Next slide. And community members reported that their most common barriers to engaging with MMRCs were these 3 areas. 1 being subordinate inclusion. Community members reported that while MMRCs may express a desire for including community voices and members, their expertise and positionality were not as valued as other members on the committee. 2nd, community members reported facing transparency, data, and legislative barriers. They shared that there was a lack of transparency in MMRC processes and data, including around the recruitment process, lack of information on how decisions were made around who was invited or permitted to join, and that there was inconsistent reporting of MMRC data. And lastly, community members expressed experiencing harmful dynamics on MMRCs. They reported on the harm they undergo from participating in MMRC meetings and serving on committees where the culture of the MMRC was unwelcoming. Next slide. Community members also shared several potential strategies for how MMRCs can improve their review processes. And our report contains a set of recommendations for MMRCs as well as the CDC. The recommendations for MMRCs are on the screen. And since the publication of the report, BMMA has been partnering with the CDC Foundation, and select state MMRCs to help prioritize and operationalize these recommendations. And today we have the good fortune of being joined by 3 states who have done a lot of work in these areas to better engage community members in their efforts to improve maternal health in their localities. Next slide. So I'm going to introduce our panelists at once in the order that they will be presenting. First, we have Dr. Martine Celaya representing Arizona. Dr. Celaya grew up in San Luis, Arizona, a resilient border city known for its vibrant Latino and migrant communities. He holds a doctorate in public health, focusing on maternal and child health, a master's in public health policy and management, and a Bachelor of Science in Health Sciences from the University of Arizona. currently serving as the Bureau Chief for the Bureau of Assessment and Evaluation in the Arizona Department of Health Service, overseeing all state and child health, chronic disease, injury, and violence. Violence program evaluation and epidemiological efforts. Dr. Celaya has over 15 years of experience in local, state, federal, and academic public health. He's the principal investigator for multiple key projects in Arizona, including the Eliminate Maternal Mortality, the Sudden Unexpected Infant Death Registry, the Sustainable Systems Development Initiative, Advancing Violence Epidemiology in Real Time, the Pregnancy Risk Assessment Monitoring System, and the Behavioral Risk Factor Surveillance Projects. His commitment to advancing the field extends to mentoring students, fellows, and federal assignees throughout his career. Dr. Celaya's expertise spans maternal and child health epidemiology, program evaluation and health equity with technical skills in statistical software, data visualization, research design methodologies, and data analytics. His career includes significant roles at the CDC and academic institutions where he has contributed to numerous public health projects and research studies aimed at improving community health outcomes. Second, we have Deja Smith representing New Mexico. Deja Smith is a full spectrum doula, certified breastfeeding specialist, prenatal Kundalini yoga instructor, certified peer support worker, mental health first aid co-facilitator, activist, advocate, executive member of New Mexico Maternal Mortality Review Committee, and mother. She's the proud owner and founder of Doc's Sacred Space, where she offers all of her services and more. Starting her maternal care services in a maternal desert in Northwest Texas, she soon uprooted and found sacred space in the beauty of New Mexico's equity coalitions and birth worker communities. Deja has dedicated her care work to reducing trauma and unnecessary biases in the healthcare industry and system, uplifting the silenced voices and integrating love and humanity into healthcare spaces in New Mexico and Texas. Third, we have Cindy Gamble, who is a citizen of the Central Council of Tlingit and Haida Indians of Alaska and one of the Kahus-Hitan, or Man's Foot Clan. She currently works as a private consultant with a focus on American Indian and Alaska Native health. She works with the American Indian Health Commission for Washington State on a variety of community health projects and is the project lead for the WIC and Nutrition Program, the Maternal and Infant Health, and the Maternal Mortality Listening Sessions projects. She currently represents the American Indian Health Commission on the State of Washington Maternal Mortality Review Panel. Cindy has worked with tribal health organizations and tribal communities in Alaska and Washington State for over 30 years as a tribal health director, a community health educator, and a tribal liaison for University of Washington and Washington State University. Cindy is currently the vice president of the Tawaks Birth Justice Board and the past president of Nutrition First, the WIC Association of Washington State. She's a volunteer with the Canoe Journey Herbalists and is currently enrolled in an Indigenous Herbalist Apprenticeship Program. Cindy believes that the health and strength of Native families and communities begin with healthy mothers and babies and integrating the wisdom and ways of our elders and ancestors into our daily lives. Cindy and her husband, Jerry, have 3 adult children and 5 grandchildren. As you can see, we have a lot of expertise from our panelists today, so I will turn it over to Dr. Martín Celaya to get us started.
All right, wonderful. Buenos dias, good morning, everyone, or tardes, afternoon. I'm going to assume that you all can hear me. If I can get someone to give me a thumbs up just to check on the mic. Okay, great. Deja helped me out. Thank you. Won't introduce myself again, but I'm really happy to be able to join you here from Phoenix, Arizona here. It is over 100 and it's really hot. And I see some of my partners in Arizona, so I know we're all keeping cool, closing our blinds and everything. So as I mentioned, today I'm speaking to you from Phoenix, Arizona, and I do want to take a moment to recognize the Otham and the Peapod people who have stewarded this land here since time immemorial, where Phoenix now currently sits. So I'll go through some of our strategies here in Arizona for engaging communities. And I also want to take this opportunity to recognize our incredible team here at the Arizona Department of Health Services. That is what we call our maternal health team, which includes Lynn Lane, Heidi Christensen, Aubrey Perez, Mary Glyden, Vivian Rubio, Samantha Davidson, and Glenda Ramirez, who form part of this initiative. So next slide. So I was asked to provide a quick overview. Oh, let me start my timer. 1 second, because I will get winded. Okay. As to how the Maternal Mortality Review Program and the Maternal Health Innovation Program coexist within the Arizona Department of Health Services. So here are two different programs with very similar intention and purpose and passion to improve maternal health outcomes in the state. The Maternal Mortality Review Program is housed within the Bureau of Assessment and Evaluation, while the Maternal Health Innovation Program is housed within the Bureau of Women and Children's Health. We are sibling bureaus within the same division, so we operate in the same space, and we're very much connected in terms of this work. The Maternal Mortality Review Program was established in 2011 through the passing of Senate Bill 1121, which added the Maternal Mortality Review Committee as a subcommittee of our Child Fatality Review team, and was awarded, we were one of those early cohorts for the Erase MM grant in 2019. And our main mission here is to review cases to identify preventive factors and recommendations, disseminate and monitor the implementation of that. Where the Maternal Health Innovation Program, or MHIP program, really supports the findings from the MMRP in the implementation of those recommendations, and are taking the lead in some significant community partnerships here in the state and large preventive efforts. And so they sustain that. But something that is common amongst both is that we share information, feedback. A lot of the meetings are joined by both staff in both teams. We also have staff that are split funded between those two programs, and that helps kind of cross the information and making and aligning efforts together, and we share resources. Next slide. This is our overall operational framework for Arizona's maternal health initiatives. This is the best way I could describe it. Of course, my partners at ADHS may have a different way of looking at it, but it is how I organized it in my brain. So we have the Maternal Health Task Force as the overarching convening of stakeholders in maternal health initiative. Under that, we have a Maternal Health Task Force Steering Committee that guides the overall task force, where we're going, where we're heading, including the development of the Maternal Mortality Action Plan. There's also a sub-task force called the Tribal Maternal Health Task Force that is very much focused on tribal-led efforts, very for us, about us, by us approach. And then we also have the Alliance for Innovation in Maternal Health Steering Committee, which helps us with the implementation of maternal safety bundles. Under that structure, we have the Maternal Mortality Review Committee, the Maternal Mental Health Work Group. We have partnerships with the Intertribal Council of Arizona that represents 21 out of the 22 federally recognized tribes here in Arizona to do some maternal health innovation programming. The Net College as well up in the Navajo Nation. And of course, our birthing hospitals that are implementing our safety bundles across the state, which is roughly around 90% of those here in Arizona. Next slide. So here are some strategies that we have worked to diversify our committee membership. I will say that each of these items came throughout the course of the implementation of the project. We mentioned that the MMRP program exists since 2011. It's taking us time to really look at this and how to diversify the committee, but also come up with new strategies. And it's an ever evolving journey is what I'm trying to say. So some of those items are here listed. We have a few things such as we have an annual membership composition survey where we just look at how the committee is structured, what kind of experiences or voices or perspectives do we have in the committee, and then match that with around what we're seeing in our maternal mortality cases and see if there is a gap in terms of any representation from certain community groups or individuals with certain lived experience that we can help recruit and bring them onto the committee. We also have governing bylaws with subcommittees that also provide an ability for committee members to provide some of their leadership into the rollout of the MMRC. We have a membership subcommittee, nominated subcommittee for our co-chairs, and a governance subcommittee. In addition to that, we have a co-chair model with term limits, and that also allows for broader representation of the committee in leadership. We conduct annual membership recruitment activities. We also work on making sure that we diversify the ways that we capture feedback in the review process. Not everyone is very comfortable with just expressing their opinion or suggestions in a Zoom manner. So sometimes we use things like polls or forms to be able to diversify the way that folks can provide input and have their input be heard and respected. We will have an annual retreat as well and an in-person review meeting, which is happening this Thursday and Friday. So that's another way to just connect and broaden our scope here in our membership. And ultimately implement genuine and inviting facilitation techniques. Next slide. And what I mean with that is practice active listening techniques, assure confidentiality and respectful interactions during the committee, ensure that there's equal participation, take breaks. We also have structured something as using first name basis rather than saying, oh, Dr. Celaya, what do you think? I'm just Martine when it comes to the committee. And that has also kind of helped diffuse a lot and make our committee process a little bit more of an even playing field so that we ensure that all voices are heard and valued as such, despite the level of education there. We have group agreements that we establish at the beginning of the meeting. And something else that we also do is we do monthly meetings with our co-chairs and community advocates. I'm going super quick on this, but we do have community representation in our committee, and we also have paid family advisors or community advocates where we compensate them for their time to participate in the committee. And so Aubrey Perez, who's our program manager, conducts monthly meetings with these advocates to make sure that they feel that their input is being valued. Also as a forum to debrief with them as to how things went in the last committee meeting, if there's anything else that we can do to help strengthen our relationships to ensure that we have that community voice, that lived experience there at the center of our review process. Next slide, please. So these are some strategies for implementing and disseminating recommendations with our communities. These happen at various levels. It's not just a one-to-one relationship. They ebb and flow, right? But most importantly, at the very top, we engage stakeholders early on and very often. And as a program, I think we do an excellent job of being very open to possibilities of sharing our information, being invited to meetings, to conferences, but also preparing tailored materials. Not all of our large, robust maternal mortality reports are easily consumable to different audiences. So we're also very open and have developed some tailored messaging, especially with our tribal partners, if they request certain type of data to be produced or for Black Maternal Health Week, we'll look at the data and see what it says there and provide some tailored messaging around that as well, utilizing multiple communication channels, having established constant feedback mechanism, advocate for policy change. And I put here partners because sometimes at MMRCs work in the space of state health departments, and we're very limited in our ability to do the capital A word, advocacy, right? However, the MMRC is just such a great opportunity to engage partners that can advocate to support the implementation of the recommendations in the MMRC, right? It's a shared responsibility that we have as an MMRP, as an MMRC, to look at those recommendations and identify the key partners that can take that recommendation and implement it. And some of those require legislative processes that we can't be involved in. However, we are able to provide the data and the rationale for why that needs to happen. And the MMRC has put it as a recommendation that it does need to happen. So sometimes that picks up legs and runs with it. Leveraging funding and resources. This is again how we partner with Maternal Mortality Grant and the MHIP grant, where we see where there's commonalities and where there's areas where the Maternal Mortality Grant can take over and when MHIP can take over. And an example of this, sometimes we leverage funds for across to make sure that we supplement an activity that is very much one of the top leading causes of maternal mortality. And so we just have those conversations here within as a group. Monitoring and evaluation, I would be remiss to say that being in a Bureau of Assessment Evaluation that we don't do constantly continuous quality improvement on our efforts. And Aubrey Perez has done an excellent job of having these biweekly meetings with us here in the program to just check in on how things are going. And there's always a spirit of, can we do better? Can we improve? How can we be more inclusive? And how can we advocate for those folks that are not participating as much or have yet to participate in the committee? So Aubrey is an excellent advocate for those voices in our program planning and really has taken us to a next level when it comes to engaging our community partners. Next slide. So this was very quick because we're given 10 minutes, but I'm happy to answer any questions or any additional information on our maternal health initiatives. We have a combined website where we have the MHIP program and the maternal mortality program housed within the azDHS.gov maternal health website. And that's kind of a one-stop shop where we put all of our training materials, our summits. We hold annual summits to disseminate the information as well. I forgot to mention that. It all can be found there. And then if you can pull up your phones, I do have a QR code for you all. If we go to the next slide really quick. So as part of our evaluation process for our various maternal mortality and HIP presentations, we have a little feedback survey that if we would love to get your feedback in terms of the presentation that I just gave. And so I don't want to take up too much time for Deja. So with that, I'll go ahead and pass it on, and I look forward to your questions or any more specifics that I can provide. Thank you.
Thank you, Martine. That was wonderful. I learned a lot in my own thought process. Hi, everybody. My name is Deja Smith. And brief, small introduction. I'm from New Mexico. In New Mexico on Tewa land in Albuquerque, and I'm here representing the New Mexico Maternal Mortality Review Committee. Next slide. So a little background about our MMRC. It started in the early 2000s, but it reconvened in 2018 after not having a committee since the 2000s whenever it first shut down. And the committee was once it restarted in 2019, we were also one of the few who got their race in grant. And whenever it initially started, it was an invitation only group that was predominantly clinical. And now that we are in the great year 2024, the committee has a maximum of 30 multidisciplinary members, all in one of many intersections of maternal health and or support, with the BIPOC members being the majority now. You can go into the next slide because it kind of meshed together. How we got here to the space of where we are bringing true humility, true knowledge, different perspectives into this cohort is in 2021, New Mexico released their first open call application to bring more community involved people, experts, and people with lived experience. Because it was seen that it was predominantly white providers and there was no one from the community or of color to be able to speak on the voices, and these were the ones who were being hurt the most. And that was with the help of the Black and Indigenous Maternal Health Policy Coalition and their efforts to change the SB 96 in legislation. And they were able to appoint 8 BIPOC members all together in one cohort with the help of some appointees from the Office of African American Affairs and also with the Office of Indian Affairs. And now we have an executive committee, which is predominantly BIPOC members, which some of my members are here representing, and some of the operational staff is from here as well, which I thank y'all for coming in and welcoming. And which brings into the culture shift of the MMRC today. We have really taken our time on creating a brave space, a sacred space of where we all are feeling comfortable enough to speak on opinions and call people into uncomfortable conversation, because we absolutely do not get it too often and we're not recognized too often, nor are we heard. So first, I'm going to be reading off of the slides, by the way, but kind of not. So with our meetings, we have now come to pretty much cleansing our space before we start our meetings. We do have group agreements. We have a land and labor acknowledgement, which was crafted by members of the MMRC of the BIPOC cohort and was actually able to present that in a CDC meeting, I believe at the beginning of this year. And then we also with each person that we're reviewing now, we don't see it as a case. We don't see it as a number. We see it as a person. We give them a name. We give them strengths. We speak on their strengths before we even delve into what we're reading about their lives. To take it a step further, we have now introduced informants, where they will go out into the community and speak to those who are willing to speak about their person and give us a little bit more insight on what they were going through, not just what we read from documentation. And that really brings it into a personal space of where you can feel who this person was and what they were going through. Which brings us into our first bullet point of Sankofa. It is a Ghanaian tribe practice of looking back to move forward. And in order for us to continue for our future to be beautiful, to be prosperous, and for all of the maternal passings to end, or at least lessen, we have to look at what's going on then, because it's gotten worse now. We, and more into the culture about it, we're very clear about how we speak about the relatedness of the pregnancy compared to the passing. We review every case, regardless of what's going on with it, and what we see or what the determination is on the notes that we're given. And we save the pregnancy relatedness for the end, because we want to make sure that we go through every detail. We want to make sure that we are presented with every step of these people's lives before we determine whether it is or isn't. We also are now asking us, how can we say that discrimination is not involved in this? Because 9 times out of 10, discrimination is happening and we don't even know it, because it's what we're learned and what we're taught about certain people of certain ethnicities. And it, as we are one of the few MMRCs in the country who are who have been doing this for 3 years now, who have had the community voices integrated with the providers, we are becoming very harmonious about what we're reading, because we know it's taught. And we'll go into the next slide before I go on into a whole soapbox. So with implementing and dissemination, we do an annual report that is provided by the Department of Health. Big thank you to Abby. She did our last one. And I'm here presenting. It was an ask, of course, but it was also an opportunity to speak about the work that we do and give people actual knowledge of what the maternal mortality review committees do. There's so many intersections of the work that we do, and to be able to speak to a plethora of people from different backgrounds, but all in the intersections, it brings open another mind to see what we can be doing different. And it also gives you an opportunity to read a little bit more about the work that we're doing and how we do it. And then making sure that our members are taking what we learn in our case reviews and in our meetings, whether it's how we view a problem, how we speak to somebody, how we're documenting things. But we take it into our daily work. That was a very big ask of our last meeting, is that we're still seeing these problems. And if ourselves are not leading that courageous step of calling people out instead of calling people in, and naming the microaggressions, naming the racism in our healthcare system, and being prominent about it, advocating for these people actively, because your inaction is also an action. And that was a quote by Dave. I may mispronounce his last name, but he gave us a good retreat this past meeting, and it really opened a lot of our eyes to what we are not doing and what we can be doing. And then this is this is a question that stumps us a little bit more but how do we get it to our communities that are greatest affected? Now, the HRSA State Maternal Health Innovations Grant, it does give us opportunity to be in spaces that are community-led, but our real goal is to collaborate with all of these local nonprofits, the coalitions, the public spaces, and in the events, and do what we're doing now is give people the real hard truth about it, but also invite them to learn a little bit more because it's affecting all of us. And that's something that we're working on now. That's something that we're truly trying to build into our foundation, that we're truly trying to uplift in our communities and figuring out how do we get it to the actual mothers who are affected by this, who are not comfortable enough to speak on it. And how do we get it into the hospitals, and how do we get it into the clinics, birthing, all of these spaces, and all these other coalitions, all of these nonprofits that are on the ground doing this work, just passing on that message. I'm pretty sure I gave a little bit more of a yoga vibe than anything strategic, but just I believe I don't have any more slides after this one. But I'm gonna go ahead and just close it out with just appreciating being here, appreciating giving this space to speak on the nature and the love and the culture of the New Mexico MMRC, and open to any questions whenever they come up. Thank you.
Hello, everyone. Really glad to see you. Martine and Deja, your presentations were just excellent. And I want to give thanks for the invitation to be here with you today. I'm really grateful. And I also want to acknowledge that I am speaking to you today from the city of Spokane, which is the traditional lands of the Spokane Tribal Nation. And I don't even have a title slide, so I'm just jumping right in. I, like Martine, was going to put on my timer to make sure that I don't go over. So I just want to say that a little background on the state of Washington, that there was maternal review happening before 2016, but that was the year that the legislature actually passed the law to put it into a mandate. And just a little background on our review panel. Our panel reviews only pregnancy-related deaths. And it is a sore point for me, and we have brought up in our committee about changing this process. As Deja says, I feel like she does, that the pregnancy-relatedness could and maybe even should be determined at the end of the review of the case, because that to me is more respectful. But just a background on the leading causes of death in Washington State: behavioral health conditions, hemorrhage, infection. As many of you, we found that 80% of our pregnancy-related deaths were preventable, which just really puts a fire under us, right? There is so much we should be doing with the action to make sure that we can decrease the number of deaths. And an important point to me is that when we look at maternal mortality rates in Washington State, many times they have been lower than the national average or lower than other states. And so if you look at it, you'd think Washington State is really doing well. And just the importance of not looking at the state, the full state rate, but looking at the groups underneath it. And that for sure in our state, that we see that non-Hispanic Blacks and non-Hispanic Native Hawaiian and Pacific Islander do have a 2.5 times higher rate than that of non-Hispanic whites. And for American Indian Alaska Native people, our maternal mortality rate is 8.5 times higher. It's the highest rate compared to any other race and ethnicity in our state. Next slide, please. And so they expanded the law in 2019 specifically to require tribal representation, so that more effort would be to bring in people from tribal nations and urban Indian organizations, and also specifically expand the representation for all sorts of provider types absolutely, but also to ensure that organizations that represent populations most affected by maternal mortality and the lack of access to maternal care were invited and impaneled. And so this did result in a more thorough panel recruitment process. It is an open application process, and it is successful. We have over 80 members on our maternal mortality review panel in Washington State. Some other things that we do is that we do have lead panel members who look in different areas so that we have a more thorough investigation and recommendations. And this year we have started to have the lead panel members meet prior to our full review meetings, and just again to help put some thoughts out there to really spark conversation among the full panel. And I really appreciate that in our maternal mortality review panel, there really is an emphasis on orientation, that we all come together as new panel members, and prior to every case review, we again get grounded in what our mission is, what we're doing here, what the definitions are. There is always a lot of communication. And at the moment of the meeting, and these days, all our meetings are still virtual. We do always emphasize the importance of the confidentiality. We also do have a moment of silence and reflection, and always remembering that we do this out of respect for the women, for the lives lost, and for the families, for the whole community, that definitely all the communities are impacted by these losses. And another thing that we have seen a need for is training for the panel members. So next slide, please. So some of the trainings that we've had, one of the first things that I said training, so I'll go to that bullet first. Some of the trainings we've had this year is they did invite the American Indian Health Commission to present on the addendum to the 2023 maternal mortality report to the legislature, which was recognizing the need for tribally driven solutions. And this was the tribal leader recommendations. We also have had an autopsy and death investigation training, a really good one on substance use disorder, the updates and complexity and MMRP review by Dr. Fortinas. And we do have an upcoming training that we're just finding a date for, on recognizing microaggressions, just as was reflected on by Deja, the importance of recognizing that in our own group. Another thing that the state did is in the 2019 report, when the tribal leaders saw the extremely high rate that American Indian Alaska Natives had, they did ask the Department of Health for some follow-up. We received some funding to do a project that we called Community Conversations on the Health of Native Pregnant, Birthing, and Postpartum People. And due to COVID at the time, we had to only do virtual meetings, but we did 5 community virtual meetings and 5 leadership meetings, and ended up being invited to put a report into the 2023 report to the legislature, which was the Tribal and Urban Indian Leadership Recommendations. Next slide, please. Some of the other things that are happening in our state, and I'm sorry, I apologize. I was really having trouble with PowerPoint, and I think it must have been after the global outage, but so I should have spelled this out. WSPC, the Washington State Perinatal Collaborative, works very closely with the Maternal Mortality Review panel recommendations, and actually uses their recommendations as a starting point for action and quality improvement strategies and activities, which is a great partnership in getting the recommendations and that moving to action. And also, for the past few years, Washington State has had birth equity projects, which is funding that people are able to apply for, and then they are able to do their birth justice and reproductive justice projects in their community. And that has been really great that some of the money, some of the projects that are coming out are really exciting. Washington State also has those 3 federal grants that are named there. And some of the other projects that they're working on are listed there too. And I just want to call out the importance of the doula certification and Medicaid reimbursement. We've gotten the doula as a certified provider type, that was passed, but we are still working on the reimbursement model. And hopefully they're hoping that can be taken care of in the next legislative session. And also team birth, where we have several pilot sites. You know how coming from a clinical background, when the team huddles in the day, at the beginning of the day, to look at who are the people we're going to see today, and what are their issues, and how are we going to approach them. We know these huddles work, and that's kind of the concept of team birth, getting everyone together on the same page. So very excited to hear how that team birth is going to work to change how the hospital culture is in providing care and loving care and welcoming care to everyone, regardless of their background. Next slide, please. As far as dissemination goes, the state has always worked on dissemination, and because of our partnership with adding the American Indian Alaska Native Addendum in the 2023 report, I have been invited to participate in a lot of the presentations this year. So it's been really fun. I just talked to Debs Gardner, my partner, and she figures we've done about 20 plus presentations locally when we're invited. It's very fun to go and speak to the local communities, but we've also gone to the state and national level, including presenting at the Washington State Public Health Association annual conference and the American Public Health Association annual meeting. One of our partners, University of Washington or UW Medicine, has their own project, the MMRP Across Washington Action Development Project, which has really been good too. They go into community and hold like a town hall. So they have a training, they talk about the maternal mortality issue, the report, the recommendations, and really try to bring it to the community level, which is really fantastic. And one of the bullets, I don't know how I forgot to put this bullet in, but a very important partner for the American Indian Health Commission is WIC, the importance of WIC as a maternal infant health presence in tribal communities and urban Indian communities. And at the national level, the National WIC Association does have a task force on maternal mortality and WIC. And so we have partnered with our WIC tribal liaison at Washington State, and we also have been doing presentations on working together to reduce maternal mortality using community and tribal wisdom. And we have also presented at the local, state, and national level on that. Okay, next slide, please. And I really want to take just a few minutes to talk about the work within the American Indian Health Commission. The American Indian Health Commission is an organization that was formed by tribal and urban Indian leaders almost 30 years ago. And the whole issue was to improve the health of American Indian Alaska Natives in our state and reduce disparities. And really the issue of maternal health is a foundational issue. And so one of the first things that happened when we got some funding was to establish a maternal infant health work group, which has been in existence for 10 plus years. And over 10 years ago, they published the Maternal Infant Health Strategic Plan. I talked about our community conversations projects, which phase 1 was virtual, but we are continuing this project, and we are now meeting in community, going to tribal and urban Indian communities and talking to them, not about maternal mortality, because we feel it's very important to talk about maternal health, the full spectrum of maternal health, which includes morbidity and mortality, so that we can invite people into the conversation. Another issue that has come up nationally and started with the delegates at the National Indian Health Board, when you look at the maternal mortality rates of our people nationally, is the idea, do we need tribally led maternal mortality review committees? Would that be a better action and a way to finally get to the roots of the matter and to action steps that are going to work in our communities. And so we have been working on that for a couple of years, first with the National Indian Health Board, and now we're had funding from the CDC Foundation. Our maternal infant health work group, we have a patient and staff survey that we're doing. One of the tribal leaders suggested this. We are looking at, from the patient perspective, what are the resources that are available to them in their community and what resources are needed. So that's been a very interesting project and it's ongoing. We are just finishing year 1 of an American Indian Alaska Native PRAMS, or Pregnancy Risk Assessment and Monitoring surveillance system project. We are very excited about doing this tribal PRAMS and going from a community and tribal leader perspective on what are the questions and what do we need to know from these new moms who have just given birth about their experience. So we're real excited about that. And we've just been awarded a tribal maternal child infant women's health needs assessment project on from the Department of Health. Okay, next slide. This is my last slide. And I wanted to just talk about what tribes are doing in our state themselves. You saw that behavioral health, overdose, and suicide are some of our highest causes of death among in Washington State. And so why I'm in Spokane today is I'm at the second tribal and state leaders tribal opioid and fentanyl summit here. And for tribes, many of the tribes have declared the fentanyl a public health crisis in their community. And so they are doing things about it themselves by gathering together, having summits, talking about action steps and what we should do. The commission also biannually has a tribal and state leaders health summit where tribal and state leaders come together and discuss all these issues and what we are going to do. The commission has legislative days. This past year, which resulted in a bill passing that allows unused state buildings to be used by tribes to open opioid use disorder treatment facilities. So tribes are really trying to be proactive about this. And this not only works for the tribal community, but these programs are also open to the broader community. So supporting these treatment communities across our state is really going to help, we hope, our fentanyl overdose crisis. And just again, the importance of the grassroots birth justice projects have been just really phenomenal and so important. So in our communities, having the input of the tribal and urban Indian leaders, but also the input from the community wisdom and those activists who say we have to have these birth justice projects in our community. And so it's a beautiful thing. And I look forward to upcoming years when this is really going to have an impact on our maternal health status. So I think that's the last one. So thank you very much. Goodness, Chish.
Thank you so much. I know that each of these speakers could have taken up the entire hour with all of their expertise and sharing of their strategies. So thank you so much to each of our panelists. I did want to open up the space for any questions, whether they be clarifying questions or additional questions for the panelists. I think people can come off mute if they would like. I did see one question in the chat, so I will read that out loud. How has engaging the community helped your panels move from looking at the maternal mortality data to advancing policy change at the state level? So I don't know if anyone would like to take that question.
I can speak a little bit to it. I know that with ours, if it wasn't for, because it was in a community coalition, it was I forget the entire name, but all due respect to Black Health New Mexico, and their peoples. You can hear my God baby here in a second. But if it wasn't for their community, like their community work, which was also from Black Health New Mexico, they started it. They recognized that, like, what was going out was not being read by us, and so they called on community engagement from other people that they knew that was in the community. So I can say that that's how we got here, how I'm here anyway.
Yeah, I'm just happy to add on an example, and I see some of our partners from Arizona here that were very instrumental in some policy change here in Arizona. So we've seen how our maternal mortality data has been used to push a lot of initiatives here recently with, I know Shadi's here from the March of Dimes from Arizona. So she has been wonderful in helping us just look at the maternal mortality data and see what is missing. And here in Arizona specifically, we were not allowed to conduct interviews with family members, right, of the decedent mothers. And so we noticed that in our review process, that is a big gap to being able to understand the circumstances surrounding that death. And through Shadi's leadership and partnership, there was a Senate bill that was just recently passed so that they could amend the state legislature so that we can do interviews with family members. And so that's going to start on January 2025. So thank you, Shadi. So we're really excited to get that. Of course, as our what's it called? Breakthrough report, our first report for maternal mortality, it was around the time that Arizona also extended post coverage Medicaid past the 1 year. And so again, that is also very much rooted in some of our recommendations here that the MMRC has put out for extending coverage. There's other things such as the Arizona Psychiatric Access Line, APAL, which was established also as out of one of the recommendations that came out in partnership with our folks, our agency, Medicaid agency called Access as well. So we've all along, we've seen some of these examples of big P policy and little p programmatic as well, programmatic decisions in terms of allocation of resources to community groups such as our tribal partners and other communities that would normally not be included in these kind of large statewide contracting systems. So those are just some examples that we have from Arizona.
And Cindy, did you want to say anything? I saw you come off mute.
Oh, yes, I think that the same, the numbers, the data, when the tribal leaders saw that, they just, that's what prompted them to say, okay, we need some follow-up, we need some help. And that has just really opened the door for a lot of our community work, which has been important. And yes, I think as a state, definitely a lot of the policies that have been passed, the 12-year Medicaid expansion, the whole support around supporting doulas, now looking at midwives. I mean, there are just so many things that have come up due to looking at not just this overall state, but looking at all the different groups within our state and how they are really faring. So I think it's been really important.
And while you're unmuted, there's a specific question for you, which is, can you elaborate on the partnership with the university? Is the purpose of the partnership more awareness, education, or action-oriented? And if so, how have these actions been supported and implemented by partners?
Well, I know that Dr. Ian Bennett is one of our MMRP members, a long-standing member. And I think he was pretty instrumental in getting funding. So they were funded by the Department of Health. And so this is their second year in going across Washington. And it's to bring the data and the conversation to communities so that people can come and talk about it. And I think eventually the whole idea is about action. But, it has to start with knowledge first and getting people on the same awareness of what is really going on. And I just feel there's just such a movement to get everyone more involved in it's all of our jobs to think about the health of our women and children. It's not just MIH people, it's just not doctors, it's all of ours. And so I appreciate that they are bringing it to community so that they can see themselves in their role in improving maternal infant health in everywhere, in our homes, in our communities, in our nation. So I think that's their issue, is they just want to be more action oriented too. And it's been pretty exciting.
This is Allison piping in from MHLIC again to say thank you so very much to our panelists and to Black Mamas Matter Alliance for putting this event together. I am sorry to say that we're out of time because I would love to hang out in this space with you a lot longer. We did record this event and we will be sending out the recording to everyone who registered. Please also keep an eye on your inbox because we will be sending out an email for an evaluation of the event overall. And I think all of us know how important these evaluations are for multiple reasons. For our panelists who have perhaps not been focusing on the chat, I want you to know you have received much love. Folks are really appreciating everything that you've been sharing today. Thank you again for your time, and I hope everyone is having a wonderful day and continues to do so.